Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering leukemia as promised. Before we even get started, guys, I'm going to ask you to do a couple things for me to help support this channel. Like this video, you're going to love it, so go ahead, press that like button, subscribe to this channel if you haven't done so already, and you'll be notified every time a new video is released. Don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com, and please, as always, engage with me in the comments section. It helps with the algorithm. I read all of your comments. I try to respond to as many as possible, but I definitely read the comments, and I have a running list going of any videos that you'd like for me to make in the future, whether they're questions or content lesson format like I'm doing right now. All right, guys, so let me make this a little bit bigger for you. Leukemia. So look what it says. It says leukemia. This is a general term used to describe a group of malignant disorders. Now, I already talked to you guys about malignancy. Malignant disorders affecting blood and blood-forming tissues of the bone marrow, lymph system, and spleen. That says a lot to us. Of the bone marrow, remember, those are where our blood cells are being made. RBCs. So you'd be thinking of anemia. Platelets, patient be at risk for bleeding. WBC, patient be at risk for what? Infection. Lymph system and spleen, what are those important in? Immunity. So this person with leukemia, we already know just by that one sentence, we know they're going to be at high risk for infections, for anemias, for bleeding, right? So take a look. I wrote this down because I just wanted you to know it in simpler terms. Leukemia, this is an increase in, and that's your keyword, immature WBCs. So you have all of these WBCs that are doing absolutely nothing. Remember, those WBCs, those white blood cells, are supposed to help you fight off infection. So you would think the more WBCs you have, okay, even better, you're fighting off infection even more. But no, all of those WBCs that increase in the production of RBCs, and the production of WBCs is for nothing. Why? Because they're immature. They can't do nothing. Okay? Increase in immature WBCs that take up space that there could have been RBCs, there could have been platelets, right? So it's taking up space and doing absolutely nothing. That's what's happening in leukemia. Let's take a look at classification. The leukemia develops after a malignant transformation of a single type of immature hemopoietic cell, followed by cellular replication and expansion of that malignant clone. So it keeps reproducing, but they're all what? Immature. Chronic leukemias involve more mature forms of the WBC, and the disease onset is more gradual. And that's actually a pattern for when it comes to chronic diseases and disorders. They're more insidious. They don't, what's the word I'm looking for? They're not acute. Chronic disorders are more gradual. They're more insidious. They just kind of like creep up on you versus acute, okay? We have AML and ALL. So we're going to talk about the AML first, acute myelogenous leukemia. And on the side, I wrote here more adults, because when you think of the AML, I want you to think about adults. Adults are affected more with this disease than children, okay? With AML, the onset is abrupt, as in acute, like that. It's abrupt and dramatic. Patients may have serious infections and abnormal bleeding. Why serious infections? Because it's got WBCs, it's not doing anything. Why abnormal bleeding? Remember, in the bone cells, what's made? Our RBCs, our WBCs, and our platelets. Our platelets, which help us clot and not bleed to death. Okay, so now you have all these WBCs taking the space of what should have been normal, healthy cells. Of course, yes, that's going to put the patient at risk for. AML is characterized by uncontrolled proliferation of myeloblasts, which are the precursors of granulocytes. There's hyperplasia of the bone marrow. The clinical manifestations are usually related to replacement of the normal hematopoietic cells in the bone marrow by leukemic myeloblasts, and to a lesser extent, infiltration of other organ and tissues. So these cells, which are doing nothing but causing harm, are taking place of where other normal cells should have been. And it's not only happening in the bone marrow, it's also happening in other tissues and organs. And we'll look at that in a second. Now let's look at ALL. When you think of ALL, see on the side, I wrote, what did I write on the side? I wrote more children. This affects children more than it does adults, okay? In ALL, the acute lymphocytic leukemia, small lymphocytes proliferate in the bone marrow. Most are B cell origin. The majority of patients have a fever at the time of diagnosis. Signs and symptoms may appear abruptly with bleeding, you need to know that, fever, or they may be insidious. That word insidious means sneaky, right? They may be insidious with progressive weakness, fatigue, bone and or joint pain, and bleeding tendencies. You need to know that. CNS manifestations are especially common in ALL, and they represent a serious problem. Leukemic meningitis caused by arachnoid infiltration occurs in many patients with ALL. So let's take a look. Let's take a look at the difference between our AML and the ALL. Something I want to bring to your attention, I'm not going to read all of this, guys, you can read that on your own, but something I want to bring to your attention when it comes to the ALL, remember the ALL, we see this more in what? Children, right? Look at these neurological manifestations, CNS involvement. And whenever that CNS is involved, you're expecting to see a decrease in cognition and how the person thinks. Look at this increased intracranial pressure, and that could cause the nausea, vomiting, lethargy, cranial nerve dysfunction, secondary to meningeal infiltration. Okay, other signs and symptoms that you can see in both is going to be your weakness, your fatigue, your bleeding. Okay, those you'll see in both, but specifically for the ALL, I want you to remember that children are more affected, and I want you to remember those neurological manifestations. Clinical manifestations, signs and symptoms. All right, clinical manifestations, they relate to the problems caused by bone marrow failure and the formation of leukemic infiltrates. Bone marrow failure results from one, the bone marrow, look at that, guys, overcrowding. Overcrowding by abnormal cells, which means there's no room for the actual good cells that are functioning. And two, inadequate production of normal marrow elements. So what happens after a while of the body making all of this abnormal cells, the bone marrow will actually slow down or even stop making the normal cells because you already have so much of it, even though it's abnormal. The patient is predisposed to anemia. Why are they predisposed to anemia? Because of the decrease in RBC. Remember, RBCs carry hemoglobin. Hemoglobin carries what? Oxygen. Thrombocytopenia. Why? Because of the decreased number of platelets and decrease in the number of function of WBCs. And we know that because in leukemia, all it is a proliferation and increase in immature WBCs. The abnormal WBCs continue to accumulate because they do not go through the normal life cycle to death. The leukemic cells may infiltrate the patient's organs, leading to problems such as splenomegaly when it gets into spleen, hepatomegaly when it gets into the liver, lymphadenopathy when it gets into those lymph nodes, bone pain, meningeal irritation, and oral lesions. A highly leukemic white count in the peripheral blood, more than 100,000, can cause the blood to thicken and potentially block circulatory pathways. Guys, remember, the blood is what's carrying oxygen. The tissues, the organ, every cell in the body needs oxygen to survive. Okay, so this is called leucostasis, and it can be life-threatening. That can cause the patient to die. Take a look at this figure. So it says leukemia, proliferation of immature, that's our keyword, immature white blood cells. And over here, bone marrow failure. Blast cells replace bone marrow. And look how it's affected. The erythrocytes can cause anemia that causes that patient to have the weakness and pallor. It affects the lymphocytes that causes immunosuppression. Remember, I told you how those lymph nodes in the spleen are associated with what? Immunity. So when it affects those lymph nodes, you better expect that patient's going to have immunosuppression, which puts them at risk for infection, fever. Platelets. Remember, in the bone marrow, guys, WBC, RBC, and platelets are formed. So it affects the platelets, which causes decreased clotting, excuse me. And that decreased clotting puts the patient at risk for what? Bleeding disorders. Patient has thrombocytopenia. Thrombo, clot, cyto, that cell, penia, a little bit of clot cells. That's what? Platelets. And we'll see petechiae, bruising, and purpura. Now on this side, because of leukemia, that proliferation of immature white blood cells, the cells infiltrate sites outside of the bone marrow as well, such as what? The brain, and that's how you will see all those CNS symptoms, testicles, other organs, lymph nodes, liver, spleen, and joints. Guys, I know as students, you love skipping over those tables, those diagrams, those charts, those figures, those illustrations, those nursing alerts. But guess what? Those are where your test questions are coming from. If the author of the book took time to give you an illustration or chart or table or figure or whatever it is, to give you another way of looking at information that they gave to you in text, that means it's important. It's so important they're giving it to you in another format because they really want you to know it. Most likely you're going to see it on an exam. So stop skipping over them, guys. All right, diagnostic studies, peripheral blood evaluation, and bone marrow examinations. Okay, those are the primary methods used for diagnosing and classifying the types of leukemia. Okay, peripheral blood smear and bone marrow evaluation. Interprofessional care. Once a diagnosis of leukemia has been made, care is focused on the initial goal of attaining remission. Because chemotherapy is the mainstay of treatment, you have to understand the principles of cancer chemo. So I'm going to jump over to those principles because there are lots of things that can happen with chemo, because chemo, yes, chemo can kill those bad cells, but they can also kill those good cells as well. And so they can cause other disorders in the patient. You have to know how to care for them. So let me switch over and then I'll come back here. Let me fold this over so I don't forget where I was. All right, so let's start with the GI system, the stomatitis, mucositis, esophagitis. Nursing management for those. Make sure you're always assessing the patient's oral mucosa. You're going to be looking for lesions. Encourage nutritional supplements. Why? Because if that patient has those oral lesions, you think they're going to want to eat? No. And remember, nutrition is part of physiological integrity. That is part of the things that keeps the patient alive. So they have to eat. So you can encourage them to drink maybe Ensure, Carnation Instant Breakfast. Instruct them to avoid irritating, spicy, or acidic foods, or foods that are too hot or too cold. Remember, they have lesions in their mouth. It's already painful for them. So you don't want them eating anything that's spicy or too hot. Okay, teach them to avoid extremes in temperature. Instruct them how to select moist, bland, and softer foods. We want foods that are very easy for them to chew, that will not irritate their oral mucosa that's already irritated. Encourage the patient to use artificial saliva to manage dryness from the radiation. Discourage the use of irritants such as tobacco and alcohol. Stay away from them. All right, for nausea and vomiting. Nausea and vomiting is a very common adverse effect of chemotherapy radiation. You're going to encourage the patient to eat and drink when they're not nauseated. You're going to give antiemetics prophylactically before chemo. We know chemo causes nausea and vomiting. So before chemo, we're going to go ahead and give them that antiemetic prophylactically. For anorexia, patient doesn't want to eat, we're going to be monitoring their weight. We're going to encourage the patient to eat small, frequent meals. Small, frequent meals is good for GI irritation, okay? But those small, frequent meals, we want them to be high in protein. Why? Protein is not only good for building muscle, protein is also good for wound healing. Okay, we're going to ask them to eat high protein and high calorie foods because this patient doesn't want to eat. So the little bit that they do eat, we want them to be of high calorie value. Serve food in pleasant environment. Why would you put a plate of food for your patient and right next to them is the emesis basin? There might be some sputum in there or something, right? So make sure it's a pleasant environment so that patient will want to eat. For diarrhea, you're going to encourage low fiber, right? They don't need any more fiber. They've got diarrhea. Low fiber, low residue diet. Encourage fluid intake of at least 3 liters per day because with diarrhea, that patient's losing fluid and electrolytes that were in the GI tract. We don't want that patient to be dehydrated, so we're going to encourage fluids. Constipation, you're going to encourage high fiber foods and increase in fluids. That fluid, guys, is going to help make the stool not be as hard so the patient can pass the stool easier. Increase activity, you know that, moving around, walking, that increase in activity increases the peristalsis in the GI tract. How about leukopenia? Leuco type, what do you think of leuco when you hear leuco? Like leukocytes type of WBC, penia, little bit of. So what are we going to do for that? We're going to obviously monitor the WBC count, report any temperature elevation, because remember guys, those leukocytes, which is a type of WBC, they help fight off infection. If this patient's WBCs are low, their leukocytes are low, they're at risk for infection. So the first hint of infection, such as fever, redness at a site, inflammation, any sign and symptom of infection, we're going to report immediately. So you're going to report temperature elevation and any other manifestation of infection. Teach the patient to avoid large crowds and people with infections. This person, excuse me, is already immunocompromised. You think they need to go on a crowded bus or a subway or a concert? Absolutely not. We want to keep them safe and away from infection. Thrombocytopenia, thrombo, clots, cytocell, a little bit of. This patient has a little bit of platelets, which puts them at risk for hemorrhaging or bleeding. So we're going to observe the site for signs of bleeding, such as petechiae, ecchymosis. We're going to monitor the platelet count. Integumentary system, alopecia. We're going to suggest ways to cope with hair loss, such as hair pieces, scarves, wigs. Let me explain something about this because this has shown up on NCLEX enough times for me to mention it. So when it comes to this, guys, you want to help the patient pick out a wig before they start chemo radiation. All right. And what you do is before they start, you want to help them pick out a wig that is closest to their hair color, closest to their hair structure, their hair type. Why? Because it's not when their hair is thinning and brittle and falling out. That's when they're looking for a wig, because most likely they're already going to be depressed as it is. So you want to help the patient choose that wig before they start, preferably. Okay. Cut long hair before therapy, not when they're getting therapy and they're seeing that hair become dry and brittle and fall out. Okay, lastly, cognitive changes where the CNS is involved. That's known as the chemo brain. You're going to teach the patient to use a detailed planner because they may forget things. So you're going to teach them to use a very detailed planner, to exercise their brain, play word games. They can play word games on their phone, puzzles, do things to exercise their brains. Focus on one thing. Don't try to I can't speak. Don't try to multitask. Focus on one thing at a time, and that will help with what's known as a chemo brain. All right, let's go back to the page that I was on. Nursing implementation. Important nursing interventions include: 1, maximizing the patient's physical functioning. We want that patient to move around as much as possible. We want that patient to do as much for themselves as possible. Remember, one of our goals is always going to be patient independence. 2, teach patients that the acute side effects of treatment are usually temporary. And you have to tell them that, because they will go into a depression if they don't know that it's usually temporary. And 3, encourage patients to discuss their quality of life issues. Now, while you can make these decisions for yourself and you can speak for yourself, what would you like in the case of that you become incapacitated and you cannot make those decisions? The needs of the patient with leukemia are best met by an interprofessional team: psychiatrists, oncology, clinical nurse specialists, case manager, dietitians, a chaplain, social worker. Let's talk about this for a minute. Obviously, the psychiatrist, because as I said, guys, this is a very pervasive disorder, okay? And lots of patients who have to have this disease, or they go through chemo, radiation, it causes some sort of depression, okay? So we want to have psychiatry in on it. Of course, oncology, that's a cancer nurse on it. Case manager. Case manager makes sure that the ball isn't dropped during transfer. So if the patient's leaving that acute care facility and they're going to rehab, or they're going to home, they're going to make sure that there's home health, or, you know, just make sure that everybody's on board so there's no gap in care. Dietitian, and that's very important, especially, guys, this patient is going to be on a special diet. Chaplain to meet those spiritual needs. Social workers to help that patient find resources in the community, specifically if there are financial deficits. Maybe the patient, you know, because this is a very expensive disease to have. Chemo and radiation is not cheap. So there may be some financial constraints that the social worker can help the patient and the family with. The life-threatening results of bone marrow suppression. Again, how many times have we seen this, guys? Neutropenia, thrombocytopenia, and anemia require aggressive nursing interventions. Teach the patient caregiver about the importance of continued diligence in disease management and the need for follow-up care. And guys, that's your leukemia in a nutshell. Much easier than you thought, right? I know it was. If you haven't done so already, guys, please like this video, subscribe to my channel, support my channel by engaging with me in the comment section. Let me know what you thought about this video. Let me know what you'd like to see me cover next. Don't forget, guys, I have audio lessons available for you on my website, nexusnursinginstitute.com. And almost every single day, you can find me doing different test questions on my other social media platforms, TikTok, Instagram, and Facebook. Thank you for watching this video, and you guys will see me on the next video.